Good morning, everyone. My topic is role of 3D heads-up digitally assisted vitreoretinal surgery in patients with primary and recurrent rhegmatogenous retinal detachment with proliferative vitreoretinopathy, a prospective randomized controlled trial. I have no financial disclosures to make. The conventional intraoperative viewing includes looking through binoculars of microscope, which leads to a head-down position, which is associated with musculoskeletal disabilities to the surgeon, which leads to decrease in surgeon's longevity. 3D digitally assisted system is a new means of intraoperative visualization. This is a passive system in which the two images are mixed horizontally and then separated by polarized glasses worn by the surgeon. Each eye of the surgeon sees a slightly horizontally disparate image and they are fused which leads to perception of depth. The binoculars of microscope are removed and it is replaced with a high definition camera which transmits the images through fiber optic transmission to a 55-inch 4K display, which is kept at 1 meter from the surgeon. The proposed advantages includes better ergonomic surgeon's posture, better depth of field, lower endo-illumination levels, better resolution and contrast, enhanced magnification, better peripheral visualization, and it is also a superior teaching tool. The aim of a study was to compare the outcomes of 3D heads-up digitally assisted vitreoretinal surgery and conventional analog microscope in eyes with primary and recurrent RRD with proliferative vitreoretinopathy. The study began after obtaining ethical clearance from the Institute Ethics Committee. It was a prospective randomized controlled trial with 68 patients, 50 had primary RD and 18 had recurrent RD who were followed up for 3 months. The primary objective was anatomical success in terms of redetachment rate, and secondary objectives were post-op BCVA, duration of surgery, complications, and surgeon and observer satisfaction score. Phakic and pseudophakic patients of age more than 18 years who were willing to consent and had primary or recurrent RD with PVR more than C1 were included. They could have any refractive error. We excluded the patients with other visually significant diseases like primary open-angle glaucoma, disc pallor, age-related macular degeneration, and corneal opacity. Traumatic or secondary RDs were also excluded, and we also excluded aphakics from our study. The patients who met the eligibility criteria underwent a detailed pre-treatment workup, which included visual acuity, intraocular pressure, anterior segment examination, posterior segment examination, SWEP source OCD, and Optos CP for the documentation, and they were randomized to either group using computer-based allocation method. All patients underwent encerclage followed by 23-gauge vitreoretinal surgery with silicone oil insertion. In 3D group, white balance was adjusted before every surgery. Iris aperture of the camera was opened at 30%. Microscope illumination level was 42% for 3D group and 80% for conventional analog microscope. Endo illumination levels were adjusted as per the need. And at the end of surgery, both surgeon and observers were given the satisfaction scores to fill. Coming to results, the baseline data in terms of age, gender distribution, exit length, and duration of RD was comparable in all the 4 subgroups of both the groups. Most of the patients in all the 4 subgroups had either no surgery in the past or had a history of uncomplicated cataract surgery in the past. One patient in primary RD group has a history of YAG capsulotomy, and 5 patients had a history of complicated cataract surgery. The severity of proliferative vitreoretinopathy in terms of anterior and posterior PVR was also equally distributed in all the 4 subgroups. One patient operated on 3D DAVs with primary RD had CD, while 4 patients in conventional group had preoperative choroidal detachment. Coming to primary outcomes, at the end of 3 months, 2 patients in 3D group and 3 patients in conventional analog microscope had a redetachment. This difference was statistically insignificant. Similarly, even in the recurrent RRD group, we had a similar outcomes in terms of redetachment rate. The mean best corrected visual acuity also improved significantly at the end of 3 months, and there was no significant difference in all the 4 groups. Duration of surgery was similar in both the groups, as we can see here. And the endo illumination levels, however, significantly lower in 3D group of both primary and recurrent RD. The complications seen were iatrogenic break and subretinal oil or PFCL. These were also equally distributed in both the subgroups with no specific differences. Analysis of surgical satisfaction score showed that 3D system was a clear winner in all the fields, including comfort, visibility, visualization, and simplicity of use, except 4 genres, that is MIOCT quality and absence of eye fatigue, back pain, and neck pain, where both conventional and 3D DAVs were similar as per our surgeon. All our observers found 3D system to be a better tool in terms of understanding the anatomy and comprehending the surgical steps being performed, which makes 3D system an excellent teaching tool. Our study had certain limitations, that is, it was a small sample size, short follow-up duration, and silicone oil removal was not done in the stipulated time, so we cannot comment on any difference between post-SOR detachments. So to conclude, 3D system is a safe and efficacious means of performing vitreoretinal surgeries. Surgical outcome, duration of surgery, and complications were comparable. Endoillumination levels were lower, which protects from macular phototoxicity, better peripheral visualization, and a better teaching tool. So based on these findings, we recommend the introduction of 3D system in medical colleges and fellow training institutes if economically and logistically feasible. Thank you.
Thank you, doctor. I think in the last line, you have concluded everything. Everything is good except the cost.
Yes,
and
sir.
Of course, we should start in all institutions, those who can afford. So we can buy our comfort with the cost. Of course, with the time,
sir, one question,
technology
sir.
is always, pardon?
Sir, it is beneficial for the postgraduate institutes, sir, definitely.
Absolutely.
All the training institutes, sir.
Yeah, training institutes, definitely.
Yeah. Let's start with training institutes, big institutes, and those who can afford. And then technology is always welcome. Technology with time, as the prices will go down, I think it will come to, many ophthalmologists, and it's always welcome. I think 62% of the ophthalmologists, they have said they are suffering from ergonomic problems. They are having neck pain or something. Even I am having neck pain myself. What to tell others? So I think I wish I also buy this, and so that we can do. Especially this is being used in anterior segment surgery and
yes,
quite
sir, in anterior
other
segment
centers.
as well.
And cataract surgery also to be done very clearly.
Yes, sir. Various surgeries, cataract, trabeculectomy, even
yes.
Penetrating keratoplasty is being done on this.
It is to be done very clearly.
I think it will be more useful for vitreoretinal surgeries, which take much longer.
Yes, sir.
And this instrument can really save our neck or neck of the retina surgeons.
Yes, sir.
Yeah. So thank you very much. It was a nice talk.
Thank you, sir.
You have presented it well.
Thank you, sir.
Thank you very much.